Hello and welcome to another episode of Premier Pain Talk. I'm your host, Dr. Michael Danko, with Premier Pain Treatment Institute in Cincinnati, Ohio. I am a board-certified anesthesiologist and pain medicine specialist. Today is an episode I'm going to be shifted a little more towards two groups of people, newer providers to pain management. So potentially, a newer physician or a newer advanced practice provider who's getting started in pain management, and also to patients. So obviously, and most importantly, I think without people needing help with their chronic pain, then none of these procedures and treatments we do are really necessary or worth talking about. So I think it's really important that we do our best to try to educate our patients and help them understand. And this is kind of one route where I'm hoping to do some of that. If you are an advanced, physician with a lot of experience, I apologize if this is too boring for you, but hopefully you'll pick up a thing or two as well. So with that, I'm going to roll into a discussion about a series of advanced procedures we do in pain management. These are a combination of minimally invasive surgeries and advanced pain procedures, a lot of times called neuromodulation. As far as neuromodulation, I know that word is kind of voodoo to a lot of patients out there listening. I remember kind of a funny story one time where the man behind the scenes, who's really the our guru for social media and for this podcast production, Daniel, we were fooling around with potentially an additional clinical option we were doing, and we basically very quickly agreed that patients have no clue what neuromodulation means, and so pretty funny. And so I kind of chuckle now after that conversation every time I think about neuromodulation. But basically, these are advanced procedures for pain. So I have another episode that goes over a lot of our basic procedures we do for pain. And I'm going to cover spinal cord stimulation and dorsal root ganglion stimulation. Going to cover peripheral nerve stimulation and a couple variants of that. I'm going to talk about intrathecal pain pumps, or targeted drug delivery. Going to talk about a procedure called minimally invasive lumbar decompression, or the mild procedure. Going to talk about indirect lumbar decompression, or the Vertaflex procedure. Going to talk about something called basivertebral nerve ablation. And lastly, you're going to talk about sacroiliac joint fusion. So with that, that was a whole lot of alphabet soup there. But starting from the top, we're going to talk about spinal cord stimulation and dorsal root ganglion stimulation, or what I'm going to call SCS and DRG. So spinal cord stimulation is a therapy where we're delivering energy to the spine to try to block pain impulses coming from certain regions of the axial spine and the extremities. There are a whole host of indications for spinal cord stimulation, but it's generally a treatment for conditions that have a component of neuropathic or nerve pain. The most common indication for spinal cord stimulation is something called failed back surgery syndrome. Also, it's another common indication is something called complex regional pain syndrome. And in certain conditions, it can also be used for lumbar radiculopathy, lumbar spinal stenosis, and diabetic peripheral neuropathy, and a whole host of other conditions. With this therapy, it's kind of a two-pronged approach. So we're going to first talk to the patient, get an idea of what their previous treatments are, make sure they've done their attempted conservative treatments like physical therapy and chiropractor and structured home exercise program. Make sure that they've had appropriate imaging for their issue. We're going to make sure that as far as what treatments have been tried so far, that they've exhausted the more basic interventional treatments that we might have. Make sure there's not a surgical cure or fix for their condition, and oftentimes that may require a consultation with the surgeon to rule out that surgery can be done. And then if we're at that point, we've decided that we're going to offer the therapy up. There's an insurance requirement for a psychological consultation prior to it, but once we've hit all those prereqs, then we get approval for something called a trial. And the spinal cord stimulator trial is typically a 7-day trial. It can be as short as 3 days. And then across the pond over in Europe and other places, they'll oftentimes do longer trials where even as long as a month. But most common trial over here in the U.S. is a 3 to 7 day trial where you place temporary electrodes into place, and then going to test the therapy for that duration of time, see how much pain relief you get, see how much improvement in function, see how there's improvement in patients' moods. We'll often give them some tasks so that they'll tell us some things that their pain has limited them doing. We'll ask them to go try to accomplish those during the course of that trial period, and overall to see if this is the best relief they've had in a really long time. And this is a kind of and so to speak, a try it before you buy it. So you try the therapy out, see how well it works, and then if it works, then move forward with a permanent device implantation. And with that, a permanent version of the system that was trialed is implanted. Usually two electrodes are implanted, and then a battery or a generator is implanted along with it to provide power to it. And then that's the mechanism which the patient uses that therapy in long term. A variant of spinal cord stimulation is called dorsal root ganglion stimulation, or DRG, like I mentioned before. And that is a therapy where we're targeting more specific nerve roots, typically in the lumbar spine, kind of like T11, T12 down to the whole lumbar area, and then potentially into the sacral nerve roots as well. So those are the nerves that we're potentially targeting. Target one or two nerves to try to provide a more focal pain relief or block to an area. So patient has a more focal pain. They have complex regional pain syndrome in their foot and ankle, or they have so a lot of neuropathic pain after their knee replacement. Other targets like that where we want a more specific target to the stimulation that can be accomplished by stimulating the nerve roots or the DRG, the dorsal root ganglion, which is really your information filter. So it takes the signals coming from the extremity, figures out what's important, and then sends it up the spinal cord to the brain. And so figure out how to block the pain component to that, and more specifically in that therapy we call DRG. And with DRG, very similar in terms of the leads you can place. Actually, you can implant up to 4 leads for this therapy, and then again plugs into a battery or a generator with the permanent implant. It has a trial period as well, where you try it for 3 to 7 days, and then if the trial goes well and meeting all of our goals for the treatment, then you move on to the permanent implantation. So with that, I'm going to take a real quick break, and then we're going to move into our next topic. Hello, and welcome back to Premier Pain Talk. I'm Dr. Michael Danko. With this segment, we're going to talk about peripheral nerve stimulation. So peripheral nerve stimulation is a growing therapy that in our pain space that is got a lot of indications. So in general, you're looking for 1 or 2 nerves that you can target to deliver a targeted stimulation to block pain impulses coming from that section of your body. There is kind of 2 main systems out there for peripheral nerve stimulation that are in use. There is a temporary stimulator called Sprint by a company called SPR Therapeutics, and with that treatment, the treatment is a trial. So it's typically a 2-month trial where you place 1 or 2 electrodes in place, and you stimulate the area, block the pain coming through it, and everything is external. The leads are inserted, and then everything else is kind of taped externally, and the patient will get the therapy for 2 months. And then when those leads are removed, in about 75% of people, I think it's the technical statistic might be 72%, people will oftentimes experience up to 12 months of pain relief after that therapy. And the way that the therapy is working in that setting is by that extended course of stimulation. There's some rewiring of the circuitry, so to speak, or some modulating of those nerves that happens that will take some of that aberrant or abnormal signaling and start to reverse it and get more healthy signaling. And then so when the trial leads are removed, then they get that extended period of pain relief. This is also can be used for for low back pain in a very successful way too. So you have a patient who you can target the medial branch nerves, one on each side in the low back, and potentially block that for 2 months, and then get up to 12 months pain relief for low back pain as well, which is a pretty exciting option for the patient. A more permanent peripheral nerve stimulator is very similar to a spinal cord stimulator in the way that there's two phases to it. There's typically a 3 to 7 day trial where you insert one or two stimulating electrodes into around the nerve target. You block the pain coming from the target, and then if that trial works really well, the pain relief is great, functional improvements are good, patient is very happy with the therapy, then you get a set up for a more permanent version of that. A big difference with the permanent implantation is that you're generally only inserting or implanting the wire, the stimulating wire electrode, because the receiver for it is built into the wire, and then you will use a external wireless communication with it to use the therapy. So there's not a implanted battery or generator that gets implanted with it like there is with the spinal cord stimulator. With peripheral nerve stimulation, this realistically you should be trying to identify one or two nerve targets that are blocking that pain. If you have a more generalized or diffuse pain, that's really not a great indication for this because you don't have a specific target that you're going for. And then as far as the most common indications for it, this is I would say number one indication in our practice for this is chronic knee pain. So we're targeting the infrapatellar saphenous nerve with that most commonly. It can be used for the shoulder pain when you're treating the suprascapular nerve. Cluneal neuralgia is another target that can be used as a way to help with kind of cluneal neuropathy or potentially some pain coming from the sacroiliac joints. And then foot and ankle is common. So the kind of three big nerve targets around the ankle that you can go for with the posterior tibial, with sural, and with the peroneal nerves. And ultimately, this therapy, is a nice long-term way to block this pain. So, like we talked about in the last segment with spinal cord stimulation, you kind of rule out all the other options, make sure conservative treatment has been done, make sure there's appropriate imaging if necessary, and potentially like an EMG or another study that may help narrow down a target. Make sure that basic interventions have been tried, make sure that there's not a surgical cure for the problem, get the psychological consultation, and then move forward with the trial. With the Sprint system, since that is only a temporary trial and there is no implantation, actually, that psychological evaluation is not needed. That is really more for the permanent versions of it. The last thing I want to talk about peripheral nerve stimulation is that there is a pretty exciting newer option for peripheral nerve stimulation of the medial branch nerves, but in a much different way. And this is something called reactivate or restorative neurostimulation. And so this is a specialized peripheral nerve stimulator where you're stimulating those nerves, but not in a way to block pain impulses like we do with spinal cord stimulation and with peripheral nerve stimulation, like I've already talked about. But what you're doing is you're inserting two electrodes that can be then used to stimulate the multifidus muscles in the low back. And so the patient will run a program a couple of times a day where they will cause those muscles to fire and strengthen back up. And then with extended use over time, it'll help restore those muscles and improve the core and ultimately relieve the low back pain. So this is a therapy that has pretty fantastic long-term results for it, where patients are getting several years of relief. I mean, they've studied this therapy for multiple years and shown that, the sustained pain relief duration. And even in some patients, when patients have been able to get enough restoration of those multifidus muscles, they don't even really need to use their device anymore, which is pretty fantastic because, I love my specialty and I love pain management, but there's not as many options as you might think that truly fix the problem and eliminate it. And so this is potentially a way to, restore those multifidus muscles, improve the core instability and functional instability that's going on, and get the patient in a level of functioning where that chronic back pain doesn't return. So that is called reactivate, and then the more broad category for that is called restorative neurostimulation. But it's in terms of practically speaking, how we view it, and within our insurance world we live in, that is coded in the same ways as permanent peripheral nerve stimulators. So with that, we're going to take another quick break, move on to the next topic. All right, welcome back to Premier Pain Talk. I'm Dr. Michael Danko. I'm going to talk about a therapy that is really near and dear to my heart. There have been other podcast episodes I've done on this specifically that I think would be great if you want to get more details. So I'm going to, this therapy is called targeted drug delivery or intrathecal drug delivery or a pain pump. A pain pump is not necessarily the most accurate term for this because this can be used for spasticity and what's something called a baclofen pump. Putting baclofen in that pump as well. But most common reasons for a pain pump or targeted drug delivery is chronic pain. Is also very effective in more difficult to treat cancer pain. This is a device that delivers medication directly to the intrathecal space and the receptors on the spinal cord. There are 3 FDA-approved medications for the pump. There's morphine, baclofen, and ziconotide, which is primarily neuropathic medication that blocks calcium channels. There are medications used off-label in the pumps. Nationally, actually, in the United States here, I believe that hydromorphone or what a patient might be familiar with the term Dilaudid is used almost at the same amount as morphine. So morphine and hydromorphone are 2 very common. Hydromorphone being off-label. Fentanyl is another off-label medication that can be used in the pump. There are other medications used for try to help with the neuropathic component to it with bupivacaine and clonidine also being used intrathecally. Again, these are talking off-label medications, but in the world we live in, it's more about kind of standard of care and using it appropriately within the standards of care necessarily than specific FDA indications for treatments. But as far as the device goes, you deliver the medication. There are different parameters as set by the provider managing the device, and this is a great long-term way to control the symptoms and improve functioning. There are a couple of great studies done a little over a decade ago by Dr. Greider and Dr. Hamza, where they both of them independently showed that average pain score between a 3 and 4 was sustained out through three years of therapy. And this was also, they also showed multiple metrics that improved as well, along with not just pain relief. So mood, sleep, functioning, a lot of the things we look at going beyond pain are improved. Similar to a spinal cord stimulator, a lot of the same, steps to make it through were conservative treatment and imaging and basic interventions tried, surgical cures ruled out, psychological evaluation completed. And then when you get approval for the trial, there are a couple different ways to trial. Most common way that I trial is something called a bolus trial, which is a single injection of the medication. A patient can see for about 24 hours or so how much better they feel when the medication is injected. With that, there's really no catheter or anything inserted for the trial. It's just a single injection. The patient leaves the clinic about an hour after the injection. They go go out and do their thing and see how their day goes. If that works really well, then we get them set up for an outpatient surgery to implant the pump that's going to be able to deliver the medication. And then the catheter is positioned in a place where we think we're going to most effectively treat the pain. Other physicians out there will do something called a catheter-based trial where they'll actually insert a temporary catheter, deliver the medication, potentially up to 3 days duration. Realistically, in my private practice setting, I've found that the bolus method works a lot better for our practice setup. And also the study that I mentioned from Dr. Hamza did have a section of it where it compared the bolus trial methods to the catheter trial method, and both were equally effective in determining efficacy moving forward with the pump. So there's not really a superior method to trialing from an efficacy standpoint. So I found that the bolus method is a nice, good way to assess pain relief, rule out intolerable side effects, and help the patient. The patients are, it's enough. It's a long enough duration of time that they're comfortable with their decision on whether or not they want to move forward with the device. So I love pumps. They're great therapy. We do have a couple of other episodes though, so I'd encourage you to check out the podcast feed to hear about those in more detail. And we're going to move on after a short break to our next section. All right, I'm back on Premier Pain Talk, Dr. Michael Danko. The next treatment I'm going to talk about is a fairly new therapy that's really, I think, is really taken off within our space and has a lot of potential as an unrecognized source of pain for quite a long time, and that's something called basivertebral nerve ablation. So there are large nerves that are inside your vertebral bodies and your spine called the basivertebral nerves. There's one at each level. And when someone has pain from that nerve or pain coming from that segment, we call that vertebrogenic pain. One of the ways that we believe this happens is that when there are issues with the intervertebral discs and that there are some noxious chemicals that leak into the vertebrae, those noxious chemicals that get released will irritate that nerve and then generate the pain. And so the biomarker, or I guess not biomarker, but the marker we use on imaging to establish that is happening is something called modic changes. So there are three different types of modic changes: modic 1, modic 2, and modic 3. But realistically, for this procedure in assessing candidacy, we're only looking for modic 1 and modic 2 changes. So you get an MRI, you look and you see modic 1 or modic 2 changes in the end plates of the vertebrae, and the patient has axial back pain that is worse with forward flexion, or at least not relieved by forward flexion, and or pain kind of showing that manipulating, moving around that forces on the vertebral body and generating pain. Then you do a ablation procedure where you place a cannula into the vertebral body, and then deliver a heated signal to the nerve for between 7 and 15 minutes, and that will cause an ablation to stop that nerve from carrying pain signals. This nerve does not have something called myelin around it. Does not have there's no myelin sheath, so when you burn this nerve or you ablate this nerve, it's not going to regrow. And while that might sound a little scary, realistically, it's carrying the pain signals that's causing all the pain. And so realistically, all you're really doing here is stopping that pain signal. And so it should be looked at a little more, I think, a little more exciting in the fact that since it's not going to regrow, this is a permanent fix for this problem. There's a lot to unpack with this option, but you're looking for axial back pain. Ideally it's worse with forward flexion, or at least not improved with forward flexion. The MRI patient has had an MRI scan. It shows modic changes of type 1 or type 2 at the levels that you think are appropriate to treat, and then get the patient set up for the procedure. If any of you are familiar with something called a kyphoplasty, it's fairly similar. Kyphoplasty, you're injecting cement into that vertebrae to fix a fracture. Here we're accessing the vertebrae in the same manner, but then we're directing a probe in there that we can then use to heat that nerve. So instead of injecting cement in there, we're heating the nerve and stopping the pain signals coming from that nerve, indefinitely. So with that, I'm going to take another short break, move into the next treatment.
At Premier Pain Treatment Institute, our patients always come first. Our board-certified physicians are experts at the treatment of chronic pain caused by various medical conditions, including cancer. Our goal is not only to relieve your pain, but to restore your quality of life. With locations in Hillsborough, Loveland, Middletown, and Mount Orab, there's always a location near you. We accept nearly all insurances, including Medicaid. Call us today at 513-812-PAIN or visit us online at premierpaintreatment.com.
Well, Dr. Danko back with Premier Pain Talk. This segment, we're going to talk about a procedure called minimally invasive lumbar decompression. So this is if you take the first initials for each of those four words, you get the word mild, M-I-L-D. So the mild procedure is a treatment for lumbar spinal stenosis. So with this condition, patients, having trouble with back pain and leg pain and trouble with standing and walking, they oftentimes will have something called the shopping cart sign, where you're asking when you're going through the store and shopping, you need to take a cart and lean forward. Does that help really relieve your symptoms, your pain? And then, or if you're, walking around, you need to sit down and take breaks. Like, how long can you go before you need to take a break? Those are all pretty classic symptoms for spinal stenosis. Then looking at your advanced imaging, and then you see that there is narrowing in the spine there, then they very well may be a candidate for the mild procedure. So with I like analogies, and as far as you're looking at the spinal stenosis treatment, the first, it's a lot like a clogged drain. And so when you first have that clogged drain, the first thing you might do is put some Drano down there, put some chemical in there, try to flush it out. And that's what epidural steroid injections are. You're putting a medication back there, and you're trying to treat the stenosis, using an anti-inflammatory. That doesn't work or doesn't last long enough. And then you look on the MRI and you see that in addition to this, at that level of stenosis, there's also the presence of something called ligamentum flavum hypertrophy. Then, in combination with that stenosis, that ligamentum flavum hypertrophy can be treated to decompress or create more room back there. And so that's what the mild procedure is going to be doing. We're going to make basically during the procedure, inject a little bit of contrast down the epidural space, which will help show some of the stenosis, and then make a little incision, and then go into that interlaminar space, and then we're going to use two different instruments to remove a little bit of the bone that's attaching the ligament on each side, and then as much of that ligament as we can to decompress or open up that space. And so you need a thick ligament, or you need ligamentum flavum hypertrophy seen on an MRI or a CT scan to be a candidate for this treatment, because if you don't have that, then there's nothing to decompress. You can't decompressing it isn't going to create more space. So this is a great option. This is a very safe option. So studies have shown that the safety level is really no higher than the level of an epidural steroid injection. This is more of a steady improvement type procedure, though. So I think it's really important when talking to your patients before the procedure, that they're gonna see steady improvement, but it's not going to happen right away. So typically see about 10% improvement per week, and it could take up to 6 months to really see the full duration of improvement. So I like to make the analogy with the patient that it's maybe similar to starting a new diet or starting a new exercise program, where you're not gonna go immediately to your goal weight at day one of your diet. It's gonna take some work. You need to get there, and you just kind of you need to build up some of your conditioning back up, build some of your core strength back up because once you physically create the ability to stand and walk longer, you got to start doing that. So typically tell them you want to take it incrementally and look for steady improvement. It's not going to be a flipping of a switch automatically from the relief. So, great option, very safe option. Also doesn't prevent any future surgical interventions. So if the epidural didn't work and the mild didn't work, you haven't done anything that is going to prevent a spine surgeon from going in there and doing a more advanced decompression and/or fusion to treat that problem. So I think, I think it's a great option for patients, and it's found to be very successful therapy offered in our practice. So we'll take another quick break, and we'll move into the next treatment. All right, Dr. Michael Danko back with the Premier Pain Talk. Going to move into a treatment discussion about a procedure called Vertaflex, or indirect lumbar decompression. This is a procedure that I've been doing for quite a while, realistically, it's a great procedure that has become a lot more challenging to get approved by the insurance companies, which is really, really unfortunate. But what it is, we have a patient with a condition called spinal stenosis, a condition where they're having trouble with standing and walking, when they got pain in their back and their legs, or numbness or heaviness in their legs. Improves with forward flexions, improves leaning on a shopping cart, improves with taking a break and sitting down, or leaning on the sink when they're washing their dishes. That's very likely when you look at that MRI imaging or CT imaging that they're going to have something called spinal stenosis, which is a narrowing of the spinal canal at one or more segments. So this indirect lumbar decompression is for the lumbar spine, so low back, and basically it's kind of like a little jack stand you're implanting. So you're taking a segment that's narrowed down and stenotic, and you're going to distract a little bit to create more space back there, and you're going to insert this H-shaped implant, like the letter H shaped implant that's going to sit in between the spinous processes in the back of the spine. You're going to prop that segment open, and that is why I kind of refer to it as a jack stand. So it's kind of like lifting your car up off the ground and keeping it up there. Uh, this was previously a more commonly approved procedure, but over time there was some insurance changes with coding and with the medical policies where this has unfortunately become a little more challenging to get approved. There is some newer, more advanced options to this kind of therapy, or something called a posterior lumbar fusion or interspinous fixation, or where the device is there's a lot of these devices on the market, but they're a little kind of similar to the Vertaflex, but instead of just kind of propping the segment open, it also is securing the implant is getting secured to the spinous process and maybe a little bit of the lamina to be more secure in place and to kind of quote unquote fuse into place or fuse that segment posteriorly. And so that's a kind of emerging therapy option. Again, it is a minimally invasive, safe procedure, like Vertaflex. Also, theoretically, if it is not successful, it's also, potentially going to be a scenario where a surgeon could augment that with pedicle screws or other ways to treat it without having to remove the device. But ultimately, every condition, every situation is different. But this is a little more robust way to treat the stenosis if something like the mild procedure hasn't worked, or you're not a good candidate for mild. So with that, gonna take another real short break and then gonna move into our last treatment for this episode. All right, Dr. Michael Danko, I'm back on Premier Pain Talk. This is going to be the last treatment we're going to talk about in this episode. This is called a sacroiliac joint fusion. So sacroiliac joint fusion is a procedure that is traditionally been performed by neurosurgeons and orthopedic spine surgeons for quite a long time. There's kind of started with open approaches that are fairly invasive, and then over time, as the therapy has been refined, there's been more and more minimally invasive approaches to fusing the sacroiliac joints. So sacroiliitis or sacroiliac joint pain is a condition where pain in the back of the hip, oftentimes referred to the back of the knee or side of the knee. There are different provocative maneuvers or tests that can be performed to try to really increase the specificity and sensitivity of the SI joint as the culprit. SI joint pain makes up about 25% of chronic back problems. So it's a fairly common issue and reason people have back pain. About 75% of people will have problems with their SI joint after they've had a lumbar fusion. So once you've fused those segments in the spine, and those spinal segments aren't moving anymore, then more of those forces are getting offloaded onto the SI joints, and so they're carrying a little more of the load than they were previously. There are a series of steps to getting this treatment approved. You need to make sure that conservative treatments have been exhausted, like physical therapy and chiropractic care. Need to have imaging. So there's a lot of pain generators in that area, so you need to rule out the other potential culprits. So you want to see some imaging of the lumbar spine. You want to see some imaging of the pelvis, including the SI joints. Also want to make sure there's imaging of the hip joint to make sure that this isn't actually unrecognized significant arthritis in the hip joint. And then you typically need at least one diagnostic injection of the joint and two attempts at therapeutic injections of the SI joint to try to basically narrow down the target, and also try obviously the more conservative option than fusing it, which is a steroid injection. As far as the approach to fusion, there are multiple approaches out there. That kind of broadly speaking, they separate into a posterior approach and a lateral approach. The There is a segment of the posterior approach that is, involves inserting something called an allograft or bone dowel into the joint. This is generally, had more recently that the treatment was determined to be experimental, investigational by Medicare, so potentially a harder option to get approved for your patient. But basically, you line up the joint in a posterior oblique view, and then through a series of steps, you prepare and dilate the joint and decorticate the joint, and then insert the allograft in to hopefully promote it with some DBM, decorticated bone matrix, to hopefully fuse that joint and stop the pain. Realistically, that is becoming a harder treatment option to get approved because there's, concerns about how much of a fusion is occurring and how successful that therapy is. So right now, while there's a lot of promise to it, there's not some of the level one data and the studies to support it like there is with a um, uh, some of the more long-term options, and also the devices that will transfix the joint. So when it comes to devices that transfix the joint, the posterior approach, there's a couple options out there that will just deploy some screws into both the sacrum and the ilium to stabilize it. Also, the other common approach is the lateral approach, and so this came on the market originally from a company called SI Bone with their three implant technique from a lateral approach, and that has very good level one data behind it. And then there's been other companies that come out that have had products that go laterally and go across the joint laterally and compress the joint to stabilize it and stop the pain. And so, the going into the nitty-gritty of of how those procedures are done and the different options for doing that, I think is just far beyond the scope of this podcast. But suffice it to say, what we're trying to do is stop this joint from moving so we can stop it from hurting. And the minimally invasive techniques are very safe and had potentially a nice relief. It's really important to follow the appropriate steps on the front end to make sure that your workup is appropriate and that you've really had good response to your diagnostic and therapeutic injections, and that you've also you imaged your other areas to make sure you're not missing another culprit that be causing the pain, and then you move forward with the procedure. And then as far as kind of a summary real quick of this episode, we went through several of the advanced options we have in pain management to treat chronic painful conditions. So we're always starting with conservative treatment and basic interventions. We're making sure there's not a surgical cure, that it's outside our scope or outside of our specialty. And then there's a whole host of options, like I've detailed in this episode, that we can do. So, and this is a really exciting time for patients with chronic pain because we have more and more options that are coming out, and more science and data that's being done to support these options. And realistically speaking, us as interventional pain doctors are becoming carpenters with even bigger tool belts to help you out. So I'm Dr. Michael Danko. This is Premier Pain Talk. I am from Cincinnati, Ohio. I work at a private practice called Premier Pain Treatment Institute. We have 4 different locations in the northern and eastern portions of Cincinnati. We have Loveland, Mount Orb, Hillsborough, and Middletown. If you want to learn more information about these procedures I talked about today, you can go to our website at www.premierpaintalk.com. And thank you for listening, and you can find even more great content on our podcast feed.